One of the topics I'm very passionate about is keloid excision. So keloids are different from hypertrophic scars, and they're different from atrophic scars. I oftentimes hear a lot of people use the word keloid to describe all of those scars, and it's not exactly the case. So there's a little thickened scar, a little ridge scar, something like that. I heard the word, I keloid. And then I look at that and I go, that's not a keloid, that's a hypertrophic scar. So if you're watching this video with a little bit of a raised scar, you can stop watching it, because this is not about hypertrophic scars, which actually I can briefly tell you, I just use injectables to manage, or I could do a scar revision on, which I encourage you to watch the company or the video on scar revision for that video. But keloids are a different animal. It's different in terms of the histologic, in other words, under a microscope, as well as clinical presentation. So histologically, under a microscope, the collagens look totally disarrayed. It's a completely different disease process. And oftentimes, as you know, strikes more African Americans and sometimes Asian, Hispanic, and even some whites. So a keloid, the difference clinically, when you look at it, has several features. Number one, it goes well beyond the borders of the scar. So it's not just defined on the scar, a little bit bigger than it, it goes well beyond the scar. And the second thing that's very common with keloids is they don't stop growing. They get bigger and bigger and bigger. Every time you try to do a little steroid injection, they get even worse. So I always tell my patients is that I oftentimes am the person of last resort, where I'm fixing people that have had keloids done elsewhere that just failed, or they got 10 times bigger because someone tried to cut it and didn't manage it afterwards, or they just put some steroids in it and either it didn't get better or it just got a lot worse. So keloids are oftentimes around the face, on the earlobes most commonly, the back of the head, on the scalp. But what's very interesting with keloids is they almost never occur on the central face. They occur on the jawline, they occur on the neck, they occur on the whole body, but they rarely occur in the central face. It has a tendency for the oil glands that we have to minimize the chance of these keloids from occurring. So the keloid, the way I treat keloids is I cut them out, and I do timed radiation. Okay, so that's the bottom line. But let's delve deeper into this. Let's talk about the surgery. Let's talk about a little bit of the timed radiation, talk about what all this involves. So first of all, from a scheduling perspective, I don't mind seeing you in consultation, talking about, pros, cons, limitations, which I'm doing basically right now in this video. But I tell you that I'm not going to schedule your surgery until I schedule your radiation, because the mistake is to go in there and cut out the keloid and go, okay, let's go figure out when we're going to do the radiation, because that's not acceptable. If you wait on the radiation won't work. Again, we're going to talk about radiation more in detail in a moment. So how to cut out the keloid. So my goal is cut the whole keloid out. If I can cut the whole keloid out, that's the highest chance of success. However, there are areas like the occipital keloid where I cannot get the whole keloid out because I can't close it. And if I close that scar under high tension, there's a risk that that won't heal as well. So how do I get around this? How do I get around these areas of high tension? So the way I do it, even in the earlobe, what I'll do is I will actually skive underneath the skin, enucleate, take out the whole keloid except for the skin, so there's less tension on the incision, and therefore I can get the area closed without tension, which is critical. Also, the key is to leave an area not deformed. So, for example, the earlobe. What's very common with the earlobe is seeing, I had a gentleman that has it looks like someone bit, like Mike Tyson bit part of his ear away. Well, I spend as much time not just excising the keloid, but working to reconstruct it so that the earlobe or the jawline or wherever it may be looks just like someone didn't have a keloid there. Of course, the trade-off of an excision is you're going to have a scar. But the goal is that incision over time heals as well as possible compared to just having a big ugly keloid there, right? You want something that looks very seamless. So, I can go into hours of detail of how I cut out keloids differently than other people, but those are probably the key principles to know. Now, I talked about radiation. This is what makes a big difference. Radiation is not like the big radiation that you're doing for big cancers. It's a low dose radiation focused on the skin. Why is radiation so important? Is because it takes a success rate from about 5 or 10% up past 90%. When is a success truly success? Really 5 years. But after the first 6 months to a year, that recurrence rate drops and drops and drops. So I'm hoping that 90% success rate goes to 95% in a year, and then 99% to 100% after 5 years. So we're not out of the forest for a while, but from a success rate from very, very low, in fact, not only low, but oftentimes, as I told you, if you just cut out a keloid without all this done correctly, it's 5 times the size. It's actually significantly worse. And for some of you out there hearing this, oh yeah, I should have seen Dr. Lamb. I now understand my mistake. So time radiation. Radiation must be started within 24 hours of the procedure. So if I do a keloid in the afternoon, you can do it the next morning. You can do it that next afternoon. But if you wait 2 days, the success rate drops a lot. So time radiation is so critical. The risk of radiation. There is some evidence that in low dose radiation can cause a skin cancer in that area. I really believe that evidence is very, very low in terms of the risk of that, but I would tell you, when you're talking with the radiation oncologist who's going to be performing the procedure, I don't perform the procedure, again, we're going to coordinate that. You can talk to them about what the risk is. There could be skin changes, which I really don't see that either, but the risk is you have this keloid that's not going away. So in my opinion, the good surgery plus timed radiation are the gold standards in terms of getting the tumor out and not having it have a high chance of recurrence. Now, the final things to understand is, how do I have success with these keloids? Is if there's an early recurrence, I encourage you to either see me as a bridge to inject it, or see your dermatologist, because if there's an early recurrence, you don't want to wait till it's as big as it started to be. So as I told you, I don't have a 100% success rate, but I have a 90-95% success rate with keloids compared to most places they have like a complete abysmal failure. But the other way to raise that success rate is if there's an early failure, then we've got to intervene early. And the 2 ways to intervene early is injections with 5-fluorouracil with steroids. And unlike what I talked about, I think, in a mole removal video, where I use a low-dose steroid, that composition is about 50-50, much higher dose steroids to get this down, and early intervention with steroid injections. Oftentimes, I can reverse an early keloid, but if you wait till it's big, those steroid injections are useless. So early intervention, if there's recurrence. I tell you all of this during the consult, but I'm telling you this during this virtual consult. That's very, very important. The other thing that's very important, besides early injection, is pressure. So ears in particular, back of the heads, other areas where you can wear an ACE wrap or a pressure clip on your ear. You can Google those things to find out what are the best pressure clips for keloids. I don't have a specific brand a suggestion. There's Earlums, EARLUMS, McKesson, MCKESSON makes some. But you need to buy these before you have the procedure with me if it's an ear keloid. Because let's say that starts to come back, then the first thing you want to do is get that ear clip on 24/7. And then gradually after maybe a week, 2 weeks, start backing off to 12 hours and seeing if that keloid comes back. If you have that device, it fits your ear, you've tested it, then you know that if there's a problem, you're ready to go. So don't buy this 6 months after hoping you don't need it. Buy it before. They're not expensive, and if you have it ready to go, then I feel much more comfortable that there's a lower chance of recurrence rate. If it recurs, we can fix it faster, and you don't need to go through injections, all those things. So having some kind of pressure device early on is really helpful to minimize the recurrence and to manage the recurrence if it does occur. How do you know there's a recurrence? The first thing you're going to notice is the way it feels. So if you gently touch it every day and you go, oh, now it's getting firmer, now it's getting firmer, it's getting firmer. Okay, that's a sign of recurrence. So it's before you actually see it. If you start to feel it getting harder and firmer and harder, before you see it, that's a sign that there could be recurrence and you want to manage it early on. Now, what are the keloids I don't manage? The keloids I don't manage are the ones I can't surgically remove. That's when you got to see someone else. If there's a full chest keloid this big and I can't cut it out, I hate to say I don't have an easy solution for that. One thing, I shot a video many years ago on CryoShape, which I'm still getting some requests for that. I tried it. It really didn't work well. A lot of the videos I was starting out with were just attempts. I declared that this is something new I was trying. It really caused a tremendous recovery and very low success rate. So cryotherapy on keloids, in my opinion, just don't work well. So this video on keloids hopefully will have you get a better understanding of what I usually tell you in a consultation when I see you in person.